First of all, one of perhaps the most frustrating things about epilepsy is that seizures are so unpredictable in nature. If we could predict exactly when it would happen, the lives of our patients and their families would be significantly changed. I think at last year's Epilepsy Society AES meeting, I had attended a session which was given by a patient with epilepsy, and something that she said really stands out in my mind. So she started the talk and she said that while I've prepared for this talk for several hours, I do not know if I'll be able to finish this talk because I'm not sure if I would have a seizure during the course of the next 30 minutes. And I think with that kind of a setting in mind, let me tell you what we found with our study. What we found was that there were several things that can potentially act as triggers for status epilepticus in children with Lennox-Gastaut syndrome. One of the most common triggers are actually infections. So it accounts for almost close to 40% of the etiology of status epilepticus in our patient cohort. The next most common are actually changes in their medication. So be it that the medication changed from a trade name version of their anti-seizure medication to a generic, or be it that perhaps life happens, we all forget something here and there. So despite the best efforts of all of our hardworking families, maybe there was a dose that was missed or 2 doses that were missed. And this actually accounts for close to 20% of the etiology behind status epilepticus in children with LGS. And of course, things are not black and white in the world of neurology, and especially not in epilepsy, in this refractory epilepsy syndrome. So there were many instances where the etiology was multifactorial. For example, perhaps a child had a viral gastroenteritis and was vomiting and hence was not able to tolerate their medication. The drug levels dropped, and then they ended up having a seizure and a prolonged seizure status, right? So this was something which is very striking, and this, I think, helps remove a little bit of that element of the unpredictability with seizures in epilepsy, because I feel that if we are aware that such triggers can result in seizures or result in status, this gives us an opportunity to act a little bit more quickly when we start seeing that a child who's prone to having status in the setting of an infection starts to display signs of an infection, to implement perhaps a short-term benzodiazepine therapy to reduce the chance that they might need to go to the ER or go to the ICU.
From a clinical perspective to a patient and a parent family perspective, talking about some of those triggers, are there things in which we can have conversations about with patients and families earlier about noticing triggers and identifying triggers, and just talk a little bit about the importance of having that conversation with parents and things of that sort going forward, obviously for this patient group specifically especially?
Certainly. So as I said earlier, this is a patient cohort that is in some ways perhaps one can think that they're fragile, and I think that we need to focus our attention on this cohort significantly. However, what I've seen is that the caregivers are phenomenal. They go above and beyond what I can even ask of them, and they are perhaps the best resources to help identify status and help reduce the duration of status epilepticus. The rest of us are kind of the rest of the team players to help support the patient and their family. So I think it's important to have a conversation with families about the type of status epilepticus that children can have, and have a plan in place about emergency measures that they can start taking while at home itself that can hopefully reduce the need for an ER visit and even an ICU admission, because we know both are highly utilized in this cohort.